Recorded.
Hi everyone, welcome. Tonight we have with us Dr. Douglas Brockmeyer, who I am very excited that he's here with us to talk a little bit about some of the stuff that we don't get to talk much about. So Chiari 1.5 is going to be a big thing, and you practically wrote the landmark paper in regards to this. So I'm very happy that you were able to come join us tonight. I'm going to make you the presenter so that you can share the slides that you would like. And unfortunately, I apologize, everyone. We tried really hard to get the camera working, but unfortunately, you're just going to have to take a look at me for the whole time because Dr. Brockmeyer's camera isn't working necessarily. Okay. Let me know if you got it. Perfect. Okay.
Okay. Is that working okay?
Yes. Yes.
You guys can see the talk and then you can hear me all right?
I hear you great.
Okay, great. So my name's Doug Brockmeyer, and I'm a pediatric neurosurgeon at Primary Children's Hospital in Salt Lake City. I am really excited tonight to be part of this conference, and I really appreciate Caitlin's kind introduction and the sponsorship of the Bobby Jones CSF Foundation. And my goal tonight is twofold, and one is to get everybody's questions answered. I was sent about 8 or 9 questions beforehand, and they're all really good, and we're going to cover those and go into those in detail. I also wanted to do some education about what a complex Chiari is. Believe it or not, there's a definition for what complex Chiari is, which we're going to cover. Obviously, people can have complex situations or complex cases and so forth. That's not the strict definition, and we're going to try to make that distinction. Chiaris are, like everybody's their own special snowflake in a lot of ways, and every case is a little bit different. And we treat it that way, but at the same time, we try to lump people together in intelligent ways so we can treat patients better over time. Okay, so I'm going to start off here, and here's my first slide, and that my objectives are to try to define the complex Chiari. What is it? If you have one, and you may or may not be familiar with the concept of the complex Chiari, but if you have just a straightforward run-of-the-mill Chiari versus a complex Chiari, what are the risks of having more than one surgery? That's an important question on a lot of people's minds. And I really wanted to focus on the long-term outlook of patients with complex Chiari and whether patients can have more cerebellar herniation over time. Can they develop syrinxes, or do the syrinxes go away? And what's the role of scoliosis? So we're going to cover some of these topics, and then we're going to dive into your questions. I'm going to go through this fairly quickly. So I just wanted to give you an example. Here's a boy I saw. He was 3 years old in 2004, and he had headaches in the back of his head, and he had swallowing difficulty. And I hope you can see my little cursor move. There you can see the typical Chiari malformation with the brainstem here and the spinal cord. And he underwent a standard surgery with removing the bone at the base of the skull. We shrunk these little cerebellar tonsils down, and then put a dura patch in there to create more space. And then after surgery, I saw him 6 years later. He got a scan for another reason. He was doing well, no headaches, going to school. We'd call this a success. So this is the classic sort of Chiari 1 patient. And we see these patients not infrequently, and we're pretty optimistic when we see them. Obviously, not all patients are like this, and that was the purpose of the paper that we wrote in 2012. So here's another patient who came to us. He was 2 years old, and he had developmental delay, and you can see the brainstem here in the spinal cord. It's compressed by the cerebellar tonsils. He underwent the same surgery that we did with that previous patient, shrunk the tonsils, put the graft in. And a couple years later, he came back for another scan and he was sort of better. He was 4 years old. He was sort of better, but not great. And then I followed him, and then he came back 2 years after that, and he started to drool and he started snoring again. He showed clear signs of brainstem compression. And what you see in the meantime, what's developed is this sort of craniocervical angulation here where my cursor's going. The tonsils have sort of reherniated in a way, and things are really, really tight. So with this, you would call this patient a Chiari 1.5 malformation. The definition of that, the strict definition, is where the brainstem is herniated down below the base of the skull or the foramen magnum. And you can always recognize a patient with a Chiari 1.5. Here's a good picture. If you see my cursor, see the brainstem, and you see a kink where my arrow is going. And patients always have a kink at the region of the spinal cord and the medulla as part of the 1.5, and that is below the foramen magnum. So here we got a CT scan on him, and here's the bone. You can see that the C2 bone, the odontoid bone here, part of C2, is sort of flexed back toward the brainstem. And then what we decided to do was re-explore his Chiari, redo the decompression, and then we decided to do a occipital cervical fusion procedure and move this bone forward as part of the surgery. So that's what we did. You can see the difference between the preoperative film where my cursor is going and the postoperative film. There's lots more room. And then this is what it looked like when we put the rods and screws in. And this patient did really well. I'm not going to show the postoperative films, but his symptoms went away and he did really, really well. So what we want to do is draw the distinction between these different types of Chiaris and what they can mean to different patients. So as a lot of people in the audience may know, there's 3 named types of Chiaris. The Chiari 0 is where you have fluid in the spinal cord, syringomyelia, without cerebellar or hindbrain herniation. The Chiari 1 we just talked about, where the tonsils are 5 millimeters or more below the foramen magnum. The Chiari 1.5 is where you have the tonsils, the brainstem, and sometimes even the fourth ventricle below the foramen magnum. And then sometimes there's a component of brainstem compression. In early efforts at looking at this, looked at what's called the PBC2 line, where you're just measuring how much the C2 bone or the odontoid is flexed backward. So that's part of it as well. So we published this paper in 2012, and we really tried to look at these factors to see what would lead to more complex surgeries in these complex patients. So we looked at patients with Chiari 1.5, the tonsils and the brainstem are herniated, whether they had anterior brainstem compression, a lot of times by that odontoid bone that was retroflexed, the kink in the medulla, and we looked at the angle where the bottom of the skull is attached to the upper cervical spine. One of the questions tonight is going to address that. And then we looked at syringomyelia and scoliosis as factors. So what are I just want to go over this for a minute. What are the measurements and the factors that a surgeon looks at when he's looking at these complex patients? Here's a typical patient with a complex Chiari. He's got a 1.5, and I'm going to go through those. So you look at the 1.5 by strict definition. There's a part of the brain stem, it's called the obex, that's well below the level of the foramen magnum. So the brain stem is down. That angle that we just talked about, that PBC2 angle, that's a factor as well. And then the angle, it's called the CXA, the clival cervical angle, or you could also call it the craniocervical angle. And that measures the amount of angulation where the skull is attached to the upper part of the spine. We measure that. Obviously how far the tonsils are below the foramen magnum, that's important as well. And then, we don't really have a great way of looking how much the odontoid is pushed back or retroflexed, but that was part of the analysis as well. And then the last one is a term that some of you may have heard in the past as part of this patient population, basilar invagination. And what that means is that this C2 bone, the top of the C2 bone, is pushed up into the cranial space, and it goes, the tip of that bone is above this line here. Okay, so that's what we're really looking at when we looked at the complex Chiari. So we looked at those factors, and we looked at a large number of patients that were operated on. It turned out that of all the patients who just had a typical Chiari 1, all those patients just had one surgery. They were one and done, no reoperations. And the patients with this complex anatomy had fairly significant number of extra surgeries. They had 11 of them required fusions. Some of them had transoral resections of the odontoid, which means taking out the bone, the odontoid bone from the front. So very different patient population. And so, it's not that you look at a patient like this and everybody needs all this complex surgery and fusions. We really, really drag our feet. And so what I think the indications for these types of surgeries are, you have this really complex situation, plus you have what are called bulbar symptoms, which means symptoms that comes from the brainstem. So that's swallowing problems, snoring, sleep apnea, speech problems, high-pitched nasal voice, things like that. Myelopathy means weakness or numbness in the arms and legs. Severe lifestyle limiting, incapacitating headaches, many times brought on by motion. And you can have progressive or severe unresolved syringomyelia. So the surgery entails, I'm not going to go into this in a lot of detail. You redo the Chiari surgery if necessary. You take off bone at the base of the skull if you have to. You place screws into C2 and connect it with rods to the back of the skull. And then you lay in a rib bone as a graft. And then you hold all that together. And we published our experience with that. So this concept is not new. It was first in 2004, but this is something that we've been doing a long time. And this is a typical post-operative appearance of the patient. So here's a patient with a clear complex Chiari, super tight. The foramen magnum is here. Chiari 1.5, syrinx, he has swallowing problems, and he's got a bad craniocervical angle there. We did the typical surgery on him, and the fluid in the brainstem never went away. We followed him for a year or so. He was really doing he was really doing terrible. He was having lots of headaches. So we went ahead and redid the Chiari, did the fusion procedure, moved the odont. You can see the odontoid is moved away from the brainstem, and the syrinx eventually went away completely with that. Okay, so those are examples. These are some statistical tables showing differences with the different risk factors. So if you have a 1.5 Chiari 1.5, those patients need fusions more frequently. If the craniocervical angle is less than 125 degrees, those patients sometimes need fusions. And if that one measurement of the odontoid going backward, if that's bigger than 9, then sometimes you need surgeries as well. So what we ended up with is this classification scheme that actually, so if you have a Chiari 1.5 and that angle is actually less than 125, not 130, there's not a super high risk. I would say the risk is not as high as 83%. That was the risk in the paper, but in our recent experience, it's probably less than that. It's probably more like 30 or 40%. And then the rest of the patient population is at smaller risk than that. I'm not going to go into this treatment algorithm because it doesn't really help us. This is a girl with, again, complex Chiari, really, really difficult in basilar invagination with lots of brainstem symptoms. You can see she's got fluid in her spinal cord. This is a really difficult case, and we decided to remove bone from the base of the skull, took out the bone from the front, the odontoid, and she was doing really well in 2006. And then you can see that she looks good here in 2006, but then in 2014, she comes back to see me with more symptoms more tonsillar herniation, more syrinx, and we ended up placing a stent, a tube, between the fourth ventricle and the cervical space in order to get rid of the syrinx. So the point here is that even though patients can look good after surgery, you need to continue to follow people for years afterwards. And if people have symptoms that are significant, then you don't hesitate to get more MRI images to see what's going on with them. So a lot of this just is based on the anatomy at the base of the skull. A person who looked at this carefully is a gentleman named Docling Peng, who's a physician who's made a study of this over the years. And we see lots of variations in the shape of the skull, the shape of the bone at the base of the skull from patient to patient, and the differences between where the pivot points are at the base of the skull and the upper cervical spine. These are really important concepts that we're looking at as time goes on. So some of this just boils down to basic biomechanics, believe it or not, and how your head is attached to the top of your spine. The hypothesis is that you have these risk factors, that you have these anatomical abnormalities. If you go ahead and have a surgery to relieve symptoms, you take out muscle and ligament and bone in the back of the neck that can release what's called the posterior tension band in the back. And then over time, over a period of weeks to months to years, you can get potentially settling or worsening of the forward bending at that pivot point at the base of the skull. It folds forward, and then you get progressive brainstem compression and symptoms. So what I think is going on, this is a gross oversimplification, but patients with simple Chiari malformations, have some type of, there's probably a component where the space in the back of the skull is too small, small posterior fossa volume. There's obviously some type of imbalance of the spinal fluid flow in that area that drives the symptoms. But if you open up the area and provide more space, these patients do really well. The complex patients are more difficult and certainly more complex with a lot more going on. There's probably some genetically driven factors with how the bone is formed. We just talked about all of them. And then there's these biomechanical stresses that could lead to potential failure. Preoperatively, these probably happen slowly, but if you've had surgery in the back of your neck, especially several times, it can happen more than once. And then people are just starting to look into these factors that the spinal fluid plays in Chiari, and they're looking at hydrodynamics. So that's just a really brief introduction into this complex Chiari concept. So I'm going to switch. I'm going to get rid of the talk. Does anybody have any questions at this point about the talk? I want this to be an informal meeting. And does anybody have any comments or questions?
So Doug, there are two questions in the chat that really have more to do with Chiari surgery in general and technique. So, well, one of them has to do with diagnosis. So they're asking basically about the 5 millimeter rule and your feelings about that, and then your stance on opening the dura and resecting tonsils.
Right. Yeah, I see that. I see the.
Oh, and there's another one. Yeah.
This is to Barb. Do you hold fast to the 5 millimeter rule? That's a difficult question. It gets more and more involved and more complex. There are certainly patients who have less than 5 millimeters of herniation, who have decompression surgery and do well. We're just beginning to understand the factors. It's possible it has more to do with crowding of the cerebellar tonsils at the base of the skull rather than the amount of tissue that's pushed down below the skull, if that makes sense. So the crowding may be important. We're just starting a multi-center patient registry that's sponsored by Bobby Jones CSF. And one of the factors that we're looking at is tonsillar descent, and we're not to enter patients into the study, we're not using 5 millimeters as an entry criteria. So hopefully that did you have a question? Does that answer your question, Barb?
I think so. What about the dura and resecting tonsils?
To full disclosure, I tend to be a dura opener, and I have various reasons for that. I feel I can do the surgery at a very high quality level with a very low complication rate. So I have done surgery where you just do the bony decompression. I've done a number of those over the years. When I put it to patients, I say, well, we could just do the bony reopening. We know that there's probably a 9 to 10% reoperation rate in the best of hands. If you do the dura opening, the reoperation rate is lower overall. It's like 1 to 2%, but there's a higher risk of other complications like spinal fluid leaks or chemical meningitis. And most people decide that they just want to do it once, and they don't want to have more than one surgery, and they'd rather get it over with. Does that help, Barb?
I think so. And then there's actually a really good question that came in. How does the knowledge that someone has a complex Chiari change your initial surgical approach? So I know you showed that algorithm that was like pretty involved, but
yeah, pretty involved. That's a really good question. So there are some patients that are so complex that it's clear that they need everything. They need Chiari decompression, they need bone resected, they're really, really sick, and there's no other way to get around it. But then there's a larger number of patients who have this complex anatomy, and what I do at the beginning is I point it out to the patients and we go over everything. I typically start with just the standard surgery to see what happens, and just sometimes you can get great relief, and that's all you need. That's a lot of what people do, and then I really follow carefully over time. There are patients that I know that are at high risk, that if they're not doing well after surgery, I've got a really low threshold for re-imaging, and I'd get MRIs or CTs or whatever it takes. And if it turns out they're not doing well, they're symptomatic, Chiari's coming back, things are not going well, then you're talking about a second surgery. So, something that you don't want to have to do, and I really try to drag my feet, but it is part of the initial discussion.
I have two questions kind of as a follow-up to that. So the first one is, do you ever notice that when you do that initial decompression, that even if it were a complex patient, that patient might get better and you never need to go back in at all?
That happens.
Okay.
That happens.
But, yeah. The second question really is more, how long do you follow these patients?
I follow them as long as necessary. I've seen kids sometimes 10, 12 years after surgery. I don't have an adult Chiari practice, so I don't know what the adult Chiari surgeons typically do, but some patients, it's just one post-operative visit, they're fine, they're better, and I never see them again. Some patients, I'm seeing them for 10, 12 years.
Okay. Sure. I don't know if there are any more questions specific to the presentation, or if you want to dive into the questions that were sent in. I think we can start there.
Okay, why don't we do that?
Sure.
Is that okay with everybody to go with the questions here? All right, so first question. I'm going to go ahead and read them.
Go ahead.
My daughter was diagnosed with Chiari at age 4 with a 24 millimeter herniation. She had a Chiari 1.5, pre-syrinx cloud and small cervical syrinx. She was asymptomatic, a side of mild central sleep apnea, so we decided to monitor. Over time, with growth, everything improved. She now has 11 millimeters of herniation, absent central sleep apnea, and her small cervical syrinx pretty much gone. With that said, she occasionally complains of awful stomach pains, and she gets them from what you would think would cause Chiari pains like overexertion. Sometimes they happen along with a brief headache. We were told they may be, quote, stomach migraines. The question is, what role does Chiari play in stomach migraines, and what exactly causes them? That number one, I don't know who asked the question. I'm really happy for you and your daughter. That was fantastic to watch and wait, and I'm glad things improved over time. I mean, that's really remarkable, and I'm really happy to see that. The relationship of Chiari to stomach migraines is really difficult to determine. Nobody really knows what causes stomach migraines or abdominal migraines. That's another word to use. You know, even the best pediatric neurologists in the world are not sure what happens. There's probably a relationship between some of the pain fibers, maybe in the brainstem, and the connections to the you know, the guts, you know, the viscera in your abdomen, or the nerves that are deep in your abdomen. That's probably as good as I can get as far as causation, because honestly, nobody really knows. I don't think I've seen very few patients, if any, with Chiari and stomach migraines simultaneously. So does that help at all? Am I answering your question?
I believe so. So some of the people who submit questions can't necessarily make it.
Right.
But I mean, I think that's the best that we can do, considering it's such a strange, it's so hard to say what causes what.
Right, right. Yeah, if somebody was in the audience, they wanted to reply, I'm happy to get feedback. So
Yes. So by the way, anyone can ask questions in the chat at any time. So please, I'll put a little note just to remind everybody.
All right, so let's move on to question 2. How do you get an upright flexion and extension cervical MRI needed by a neurosurgeon when none available in state or surrounding states are primary immune deficient for traveling during COVID? Boy, I really wish I knew the answer to that. There's, to my knowledge, there's only a few upright MRIs. It's difficult to get access, you know, state lines, and it's difficult to travel now. That's a hard question to answer. I honestly don't have a straight answer for it. I wish I had access to an upright MRI. I think it'd be great, but I don't have access to one either. So more to come on that.
Dr. Brockmeyer, are there any images that you can make, like, so for instance, you don't have one nearby, what images do you take to, I guess, in place of that? Does that make sense?
You mean in place of an upright MRI?
Right. What are you looking for when you get those done?
Get the MRI. You know, to be honest with you, I've been to talks where people show pictures of upright MRIs. From what I can tell, you know, the Chiaris look a little bit worse, you know, just because of gravity. There was I can comment on a really interesting paper that was published several years ago, where they took a number of patients with Chiari malformation, and they took them to the operating room. And right at the beginning of the surgery, when they were laying on their backs and they were asleep, they did an MRI, and it showed their Chiari. When they turned them over onto their abdomen, on their belly, to do the operation, they did another MRI before they opened up the back of the head, and the Chiari appeared better. Believe it or not, the tonsillar herniation would improve. And some of that's probably position that the patient is in while he's on the stomach during surgery, while they're prone. So, I mean, there's some positional changes that are happening that affect tonsillar herniation that we don't understand completely. and we're just probably, in the phase of knowledge where we're just sort of describing these things.
Mm. A question just came in the chat. Do you find that the MRI, the herniation of the tonsils is close to, okay, I understand. The cerebellar tonsils that you see on the MRI, is that what you generally see when you open up the, or when you go in there?
That is a really, really good question. And after doing this for a long time, over 25 years, and probably over 600, maybe 700 Chiari surgeries, my general feeling is that usually I can predict patients that are going to be tight when you open up. There's some patients that are just super tight, and you can tell from their preoperative MRI. But a lot of times you get in there, because there was 2 cases I did on Monday, and one of them, they both looked like they were reasonably tight when we opened up. One was, relatively open. It wasn't all that tight. The tonsils weren't that squished or tight, and we decided not to shrink the tonsils down, and we sewed a graft in. The other one was pretty dang tight, and we had to pull the tonsils out of the cervical neck area and pull them up and shrink them down to create space. So usually I can predict, but I'm not 100%. So I'd say like 80–90% of the time I can predict what I'm going to see, but not always. So that's a really good question.
That's interesting. I think we can move on to the next question while we wait for more to pop up.
Sure. So next question, I was born with bacterial meningitis. I had to get a shunt at birth for hydrocephalus. I'm now 42, and in 2009 was diagnosed with Chiari, syringomyelia, and syringobulbia, in which I had a decompression surgery done. It's now been 11 years since I had my decompression surgery. Since the decompression surgery, my symptoms each passing year seem to be getting worse. Since it was the bacterial meningitis caused these rare and severe issues to me, what does neuroscience know about the development and treatment for someone like me, someone who was born with a neurological condition and it develops into other conditions only to find out later how much limited I am to treatment? Also, how critical is my Chiari and syrinx toward my VP shunt, and what should I ask my neuro team, and what opinions are available to me? So I read this question beforehand. This is certainly complex. It's not complex in the way that sort of the official definition is for complex Chiari, but it's a really involved situation. Obviously I don't know all the details of your case. It sounds like you had hydrocephalus related Chiari, which was treated plus syringomyelia and syringobulbia. And your surgeons, sometimes you need both a Chiari decompression and a shunt to control the Chiari and the hydrocephalus. All I can say in general about your question and your situation is that many times patients like you really depend on the shunt in order to keep the syrinx under control and the Chiari under control, if that makes sense. And I don't know what advice to give you or give your team. I would say that's the first thing I would look at. Like if you came in and you were really symptomatic, the first thing I would do is look at your shunt, make sure your shunt was working okay before I would start thinking about doing any more Chiari surgery. So I'm sorry you're getting worse every year. Sometimes it could be just the fact that the shunt isn't doing the job. I mean, that's one possible cause. So does that answer this person's question if they're on the line?
I think so. So I think they mean by neuro team, they're neurologists. So I'm
Right.
assuming they're managing their symptoms. In the case of shunting and syringomyelia, what do patients have to talk to their neurologist about specifically?
Oh boy. That's a tough one, and I would say that if my general piece of advice would be that if the symptoms are worsening and you have a syrinx, then you should be talking to your neurologist about getting more imaging and following up, not being afraid to get more imaging to see what's going on. Because if you're if you have a syrinx and it's stable, or you have a syrinx and there's a shunt in it and it's stable, you should be stable with your symptoms. You shouldn't be getting worse over time. So I guess that's a sort of a simplified answer, but it's important just because you need to have that dialogue with the neurologist and be able to request films. I mean, the neurologist only knows probably so much about it. They can only do so much, and managing these issues are more surgically related. So you're asking to be referred to the neurosurgeon so you can have a discussion with them.
Okay. A question just came up. Do you find that in general, someone with a complex Chiari will get worse over time? I imagine without intervention.
That's another fantastic question. That here's my general way of thinking. So I saw a girl today in clinic who clearly had a complex Chiari, all the criteria that we just talked about. Craniocervical angle was tilted forward, big time brainstem herniation, tonsils down. She was 100% asymptomatic. And the parents wanted to know what to do. And I said, well, we're going to follow, we're going to get some imaging. But there are patients who have these problems that may or may not develop any symptoms. And just by sheer luck, I think. But I think what happens is that the important point is that once the symptoms start to occur, then they typically don't go away without intervention. Okay, that's by far and away one of the biggest just generalizations that I would make after seeing thousands of patients over a lot of years.
Right.
That patients, once they get going with their symptoms, they just don't get better on their own typically until you do something about it. So it's hard to predict if someone's going to get worse over time with the complex Chiari. I'd say that the odds over the long haul are probably against them. Maybe their symptoms don't show up till they're 20 or 30, but the odds are probably against them. And then, or even with intervention, I showed some examples where patients come in with complex Chiaris. We do the surgery. We think that we're doing great. Imaging looks good. The patient's doing fine. And they come back in 4, 5, 6, 7, 8 years later, and they got more symptoms and they need more help. They need more surgery. So that definitely happens.
Thank I think we can move on to the next question. That was really good. I'm trying to think of how I want to segue into a different topic, but let's move on to the next question first.
Okay, number 4, I have a Chiari, but I'm told my 13 millimeter herniation is not affecting me, yet when I lay down, I get a pain near the base of my skull every night. If I stay flat too long, I awaken with a strong haze-like pain and pressure in my shoulders and referred pain to the right side of my head. I don't get the typical sudden Chiari headaches. Do you think my cervical spine could be the cause, or you suspect it's a Chiari? Can Chiari affect flow only while laying down? Can affected flow cause demyelination in the thoracic spine T5? So a bunch of questions there, really complex questions. So do you think my cervical spine could be the cause? You suspect it's Chiari? It's really difficult to know without looking at the images. I think a good neurosurgeon who sees a lot of cervical spine disease and Chiari could probably sort those two issues out, at least rule out degenerative disease as a cause of your neck pain. can Chiari affect flow only while laying down? Chiari can certainly affect flow in any position, not only laying down when you're up, you know, any position. It can definitely affect CSF flow. And can affected flow cause demyelination in the thoracic spine? No, it's a separate issue. I mean, demyelination, typically, you know, caused by multiple sclerosis or other factors, is really not the pathophysiology, the way that the spinal cord gets affected with Chiari. That just doesn't happen that way. We don't see demyelination with Chiari. I see another question from Bart. Let me field that. That's a really, really good question. What symptoms in infants, toddlers, and kids, teens lead you to operate? Okay. Again, gross generalizations, but I think these are pretty accurate. Patients 4 years old and younger usually present with a slightly different syndrome than older patients. The technical term that I use is called oropharyngeal apraxia. And what that means is that they have it's from brainstem compression, and they have difficulty with swallowing. You may have speech delay, snoring, just motor regression, in various cranial nerve problems. They can have eye movement abnormalities. Really, really challenging kids. Have seen some really significant Chiari malformations, and that's, as a general rule, that is a big, a fairly big group of patients that we see. The second part of the question, kids and teens, it's almost always headaches. And it's, for me, it's lifestyle limiting headaches, and they typically are the suboccipital in the back of the head. They're brought on by coughing, straining, sneezing, exercise, stuff like that, and those are fairly common. But my threshold for recommending surgery is typically when it really starts affecting their life, that they're starting to miss school, they don't enjoy things they normally like to do. They may go outside to play after school, and they come indoors and they may lay down and not feel well, and they don't want to go outdoors. That's not normal kid behavior. And kids, 8-year-old boy or girl should be out running around having fun. And that, if you don't see that and they're not doing well and they have this significant Chiari, then I think that's reasonable grounds to operate. And the reason I say that is that once you take care of it, more often than not, the vast majority of times, probably 80% of the time, they do go back to normal life and normal activity. So that's a really, really good question. There's another question from Deanna. Okay, what is considered a good number of decompressions? For example, neurosurgeon says he performs probably 2 Chiari decompressions per month, 2 per week, 2 per day. So I'm assuming that's number of decompressions for the surgeon. Is
Yes.
that correct?
Yes.
Yeah, I would say that busy Chiari surgeons at children's hospitals, numbers that I see are probably 30 to 50 Chiaris per year. So that's about 2 per month, 2 to 3 per month. Okay, so 4 potentially. I mean, I probably do about 50 a year, more or less. I'm probably on the high side because I see a ton of Chiari patients. But if you're talking about surgeon experience, this is a reasonably straightforward surgery. I mean, I tell patients on a scale of 1 to 10, with 10 the most difficult, life-threatening surgery, the Chiari surgery is like a 5 or a 6. I mean, it's serious, and but it's not life-threatening. It's a routine type of surgery, but we should be able to manage these patients really well and manage the surgeons and get patients in and out of the hospital in a really sort of standard fashion. Okay.
Um, I just got a private question. So I do want to ask this. This is a really good question, sort of in the same vein. How many surgeries generally are unsuccessful in Chiari? And I guess complex Chiari because they would be, I guess, a little separate. And then why? What would be the reason for a failed surgery?
Yeah,
And how
that's a
common?
standing question. I would say that I think if people are honest in the best of hands, I'd say probably 10 to 20% of patients just don't get that much better. You know, that you think they would do better. I always bring them back in and say, are you better, worse, the same? You know, what's going on? You know, tell me exactly what's happening. I get a lot of post-operative imaging, and the Chiari looks good, but they're still not back to where they were before. I'd probably say that's probably 10 to 20% of the time,
Mm.
and sometimes that leads to workups of other conditions. But sometimes you do your very best and you still can't help them. And I think that's probably a fairly accurate statement.
Mm. In those cases, do they generally wind up getting reoperations or what?
Uh, that's a good question. I typically drag my feet. You know, if you got another MRI, like if the patients just aren't doing well 2 months out, and you think they should be doing well, get an MRI, take a look. If it looks like the decompression's wide open and there's no way you can help them or get them better, then I don't see the point of offering more surgery.
Mm.
And typically I don't reoperate. But if it looks like things are still tight and more decompression would help, then you're talking more surgery.
Right. I guess the reason I'm even asking that is because a lot of patients basically call our office and they'll say that their surgeon said, "Oh, I already operated on you. There's a ton of space back there. You're fine. Kind of go home."
Yeah.
um, but in a case like that, if a surgeon might be calling that a quote unquote success, what does the patient do to, I guess, get symptom relief?
Yeah, that we could talk for another hour on that. Uh, Maybe more than that. I mean, really difficult. And then you're talking about going to see neurologists, pain management specialists, maybe, trials of steroids, things like that. You're overlooking a chemical meningitis, a spinal fluid leak, just things like that are worth exploring.
Hmm. Do you, so at your institution, do you have a team that may you might be able to refer within the system? Like, is that usually how it goes, or?
Yeah, we have a headache clinic at our institution that's run by the neurologist. It's a multidisciplinary clinic with behavioral medicine, physical therapy, child life, the neurology people, and we liberally refer people back and forth between the two. I send some patients who just haven't done well after surgery. I've sent them there for further evaluation. Uh, yeah, so I guess that we do have a team. Not every place is lucky enough to have a team like that, but we're lucky enough to have one.
Um, so patients that come into your clinic, do they generally see you first, or are they seeing a neurologist first? What's the general flow?
The general flow is that every
Oh,
look at their images and
sorry
I
about that. Sorry about that. Try. Can you? The general flow is. I'm sorry. One more time.
yeah, so our at our institution, every patient that comes in with a Chiari 1 diagnosis, by radiological criteria sent in by whoever, I look at those films. And what I do is I triage them. If it looks like they barely meet the criteria for Chiari, they don't have a Chiari, but they still have headaches, I immediately refer them to the headache clinic because they're probably better served by seeing the neurology doctors and headache specialists.
Mhm.
If it looks like there's some element of a Chiari, then I typically see them directly first, personally. And there's a lot of people that don't have bad Chiaris, but they got a lot of questions, and maybe they're not getting them answered. So I'm happy to talk with them and have consultations. And in this day and age with Zoom, we see a lot of patients, throughout the West who don't have to drive. So there's a fair amount of that going on, where there's a lot of referrals that we're seeing in discussions.
Mm. After surgery, I know you said that you follow the patients for a certain amount of time, but are they also being seen by the neurologist or the PT, so the headache clinic, for example?
If it's just a straightforward Chiari that was taken care of and they're better after surgery, I don't refer them back to the headache, or refer them to the headache clinic physical therapist or that team.
Okay. All right. I'm not seeing anything new popping up, so do we want to maybe move on? What are we up to? Number 5, I think.
Number 5, I'm going to answer that one quickly. I'd like to know about the incidence of Charcot joint and neurofibromatosis. I don't know if there's a known association between those. So that's going to be, I'm unable to answer the question, unfortunately, because I just don't know there's much known about that association.
Right.
So I'll be honest and I'll say I probably can't help you there.
Yeah.
So we'll go to number 6.
Okay.
What are your thoughts and first line of action in a patient that presents with Chiari, questionable hydrocephalus, and syrinx? What has been your experience with these complex patients? That's a really good question. I think that there are a certain percentage of patients, maybe 2 to 3% of patients, who have hydrocephalus as the underlying driving factor of the Chiari, and you do a Chiari decompression and it sort of unmasks the hydrocephalus, and it happens. And there are patients who show, you look at the MRI and you only see the Chiari. You see no evidence of hydrocephalus or big ventricles. You do the procedure and the hydrocephalus gets, the ventricles get bigger, the hydrocephalus becomes evident, and then they need some type of procedure for hydrocephalus. Really difficult situations to sort out. To answer that question specifically, if you want to get into the weeds a little bit, if somebody comes in and they have big ventricles, a syrinx, Chiari, a lot of times if I'm going to do the surgery, I will put a drain into the ventricles before surgery to measure the pressure and see if hydrocephalus couldn't be driving some of the Chiari, and evaluate that as a first line of action before surgery, or before you start the Chiari surgery. So that is it's a really sort of subtle, complex situation that takes a lot of thought, and I've been surprised several times in my findings. So that's a really, really good question.
I'm getting a couple of private questions. Before we move on to the next one, because I think it'll flow in kind of well, this is more in line with just regular Chiari 1, but do you evaluate your Chiari patients for Ehlers-Danlos syndrome at the first screening, or are there any other comorbid conditions that you're looking for, I guess, in that first clinic visit?
Yeah, everybody who walks in, we do a Beighton score on them, and that's where you ask people to bend their thumbs back to try to touch their forearms. Are they double jointed and so forth? Can they touch the floor with their hands, with their knees locked, things like that. So yeah, everybody's evaluated for that, and we see lots of patients with connective tissue disorders. That's about as far as you can go. You can't really diagnose them with Ehlers-Danlos. Doing that is basically just a screening disorder or screening method. And then you're looking at the association of Ehlers-Danlos, hypermobility, craniocervical instability, things like that. And that's not what this discussion's about, but the short answer to that is yes, we screen everybody.
If someone were to pass that and they wound up having a connective tissue disorder of some kind, Does that change how you approach surgery for that patient at all, or?
Well, it depends. If they have a true blue Chiari, I just treat the Chiari. If they have a mild Chiari, but they have a lot of symptoms, or they have no Chiari and symptoms, I'm really hesitant to jump in and do surgery. I'll do everything I can to try to avoid jumping in. I have done that. Some surgeons around the country are having some pretty good results with patients like that. I think it's still a little on the controversial side. It hasn't been, proven, scientifically that the procedures consistently help the patients. But at the same time, we all need to keep an open mind, and there may be something to it. There's a lot of biomechanical factors that are involved that we don't understand completely. So maybe the fusion in that situation, or Chiari surgery in that situation, is beneficial. So I don't know the answer to that definitively.
Do we want to maybe touch on this next question 7 then?
Yeah, this is a really good one. I heard experts speak about clival axial angle in complex patients. Is it common for radiologists to include that measure in their report following a flexion extension MRI? If it is not included, is it appropriate for the patient to ask the radiologist or neurosurgeon for it? Yeah, my experience is that most radiologists really aren't familiar with the clival axial angle. So I think that's probably asking a little bit too much. If they're familiar with it, great, you can get a value. But if they don't get it, you're asking the neurosurgeon for it. It is helpful. And we're sort of running out of time here. We probably got just a few more minutes. I could spend a bunch of other time just talking about the biomechanics. There's a paper coming out in Journal of Neurosurgery where we look at the relationship of the supporting structures at the base of the skull and how it relates to the upper cervical spine, specifically the C2-3 joint in the C2-3 area, and that relationship and how it predicts surgery. We think it's a measurement that, if it catches on, would be better. It's a better measurement than like the PBC2 measurement, and it may be better than that clival axial angle. But I think there's definitely something about the bony relationship between the base of the skull and the upper spine and the biomechanics that we're just starting to sort out.
So there are 2 questions that just came up in the chat. I don't know if you mind terribly going through these really quick. They're pretty good questions.
Yeah, they're great questions. There's one: do you treat patients with basilar vagination or pineal tumor? Yeah, definitely basilar vagination. Yeah, pineal tumor is part of neurosurgery, so that that's a pineal neurosurgery problem. Next one is 14-year-old daughter lost use of right arm and was diagnosed Chiari 1, had fast decompression 4 years ago. Local hospital had syrinx, did not change, but the arm use came back, did well to 11 months ago. Other arm loss use for a week. Other symptoms began. Pain every day. Surgeon imaged, finds nothing to explain. Have seen all kinds of specialists now this year, diagnosed with POTS, dysautonomia, EDS, has tried physical therapy, gabapentin, reconditioning. Should I consult a quote Chiari specialist? Yeah, that's a really good question. I'm assuming that the neurosurgeon that you saw is well versed with Chiari. If he says that things are well decompressed and there's nothing else to do surgically, then you are going down that road of treating the other conditions. POTS, dysautonomia, hypermobility, physical therapy. There may be clinics or specialists who might be willing to see, like there are, hypermobility clinics, POTS clinics around the country that would be willing to see someone like your daughter. So that would be very reasonable. I mean, these are really, really difficult situations. uh, and finding an experienced person is important. So let's go on to the next one. In someone with radiographic indications for craniocervical instability but without bulbar symptoms, would you do further testing or just wait and see? Uh, that really depends. You know, I mean, if you're unstable, you're unstable. I mean, it really, I don't know what radiographic indications for instability are. I mean, I have my own, but if you definitely were unstable there, that the only way to fix it is to do surgical stabilization. So it's a hard question to answer. Some people call instability when it's really not there. So that's sort of a slippery topic sometimes. And if you really have true blue craniocervical instability, then my advice is, you know, see somebody who sees a lot of that kind of stuff and get a good opinion, uh, and see if further testing is necessary. You know.
Mm. So there's always one question I end with, but I do want to just insert one other question. Can you give us a 30,000-foot view of this study that we're proposing that you are doing so much work on? I just want to like kind of give everybody a feel for what the goals of this study are going to be and the larger projects that we're trying to guide through it as a pilot. I don't know if you want to speak to it a little bit. Um,
Right, correct. So yeah, that's that. Thank you. So first, I just want to thank everybody. This has been a great session. I think really good questions, really thought provoking. I hope I helped answer some questions and hopefully helped some of you in seeking care with your doctors. As far as the study that we're doing or the patient registry, what we're creating is a prospective multi-center study where we're entering patients in, and we're going to follow, and they're going to have everybody in the study is going to undergo Chiari surgery. We're going to follow them for a year. We're going to look at patient-reported outcome measures where they would be asked questions about where they thought the surgery was useful or not. And then after a year, we're going to look at all of our data, and we're going to try to determine are there certain factors that predict patients that do well, that are happy with their surgery, that are better with their symptoms, not just radiographic improvement, but symptomatic, you know, clinical improvement. When you go through a process like this, it's called a surgical severity score, and what you can do is come up with hopefully 2 or 3 factors that you can have yes or no questions to, or have some sort of value or measurement that you could apply, and you can predict that if this particular patient has these particular values or findings, then the odds of them having a good outcome from surgery is X%. And that's sort of the whole 30,000-foot view. This is the first time anybody's done a study like this multi-center prospective study. It's being sponsored by and supported by Bobby Jones CSF, and we're extremely grateful to them. We're bringing together the best people in the field, and we're really excited about it. And we're hoping to launch it sometime in the near future.
yeah, thank you. That was much more eloquent than I probably could have put it. But the last question I always ask everyone is, how can people get in touch with you? I know right now in this time of COVID, people are looking to see if maybe they can use this time wisely and get some remote consultations, or how they can get in touch with you as a Chiari specialist. So I don't know if you can just walk us through like how to get in touch with you for that.
Yeah, I think probably the best way to do it would be to contact our office. I mean, we have a formal process for this where we get referrals for spine conditions. I think that the number I have off the top of my head, there's a woman by the name of Monica in our office, and her number is 801-662 2258, and she could either help you or triage you to my nurse, who I have a nurse practitioner who works with me who runs our pediatric comprehensive spine service and does a lot of work with me and triages patients. So once you get into that pipeline, then you will be taken care of. So that's how to do it. Okay.
Awesome. Thank you so much, Dr. Brockmeyer, and thanks everyone for joining us tonight. Ooh. So I just wanted to thank everyone for coming, and I'm really glad that we got to do this, and I look forward to doing it again in the future.